Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of Health Quest, St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I'm the executive producer and host of the show. And today it is our distinct pleasure to welcome Dr. Seth Hayes. Dr. Hayes is a practicing neurosurgeon in Slidell and in Covington, affiliated with the Ochsner system. Dr. Hayes, welcome to the show.
Thank you.
Now, tell us, Dr. Hayes, what got you interested in medicine?
Initially, to be truthful, at an early age, my dad played in a old school rock and roll band, and he's not a physician, but as members of that band is comprised of kind of local family physicians where I grew up in New Iberia, and they were our family physicians. They took care of us, and it was an initial role model for me and inspiring with what they did for the community, for our family, friends, and the entire network. And I grew up watching them and being part of that, and that's I think where it all started.
Indeed, a noble profession, and you got to see the compassion and how they worked in the community, and that what great ideals to follow. Fantastic. Now it says here that you specialize in neurosurgery, minimally invasive orthopedic spine surgery, and neurological spine surgery. What are those three different types of surgery? What differentiates them?
I don't think there's any differentiator. I mean, the focus in my training, I'm a neurosurgeon by training. I spent time within my training where I focused on spine surgery, which is complex, minimally invasive, comprehensive spine surgery, with a focus on minimally invasive techniques and innovative technology. So I don't really see it as a differentiator when you look at treating the spine and spine surgery. You can classify and label it however you want, but there are older, more traditional techniques, and then there are focus on newer techniques with minimally invasive approaches, which come with great advantages. And that's kind of been the focus of my career to this point.
All right, and we see in our picture that we have up on the screen now, you've provided us with a picture of some minimally invasive procedures. Tell us about this picture.
Correct. It's just a broad network of opportunities with the goal of selecting the right procedure for the right pathology or the right problem. So there's a whole host of things that can be accomplished really over the last decade that have really propagated. These include non-fusion techniques like total disc replacements, maintaining range of motion. It also includes doing more common surgeries like a discectomy for a herniated disc, using special tubes and ports, minimizing some of the destruction of muscles and tissues. And this leads all the way into the more complex pathology involving adult degenerative scoliosis that may require more complicated fusion using these techniques and technologies.
So one of the things that we see in your practice is that you have the training and the skill to be able to deal with all sorts of different complications of the spinal column and the brain, right?
Yeah, absolutely. And it comes in a variety of simple to complex. There's never a boring day. Some things are very straightforward. Some things come with a lot more thought and evaluation. But the goal is to be able to target individualized treatment to specific problems.
Okay, and we're going to get into that as we go in through our talk this morning. Now, I do notice in our next slide that you had your training was at LSU. Was that a big charity in New Orleans, or where was that?
So I went to medical school at LSU throughout the systems. There was some time spent at different facilities throughout New Orleans, at the LSU Medical Center, throughout the community. I spent some time in different areas of the region, in Lafayette and in Baton Rouge. throughout medical school. Following medical school, I did my neurosurgery training at the University of Miami, Miller School of Medicine, and at Jackson Memorial Hospital, which is one of the larger public hospitals in the country. So in Miami, I also did a 1-year enfolded fellowship just focusing on spine and spinal techniques and spinal surgery.
So needless to say, one of the most accomplished and educated and trained neurosurgeons in the area, and a great addition to St. Tammany Parish. We're so glad you're here. Now, I have to ask this question. When LSU and the Hurricanes played in that game, I need to know what side of the field you were on.
Oh, that was easy. That was a great victory, and that was a lot of celebration on the other side. But that's never. I did struggle. My son grew up in Miami and owned a Miami Dolphins jersey, but he never bought into the Hurricane. and then following training, I've been in North Carolina for the past few years. I took a job with Duke, and I've been fortunate enough to spend time at Duke and the Duke Spine Center, and had a great experience there with wonderful partners. And
now an opportunity to come back to St. Tammany Parish. You have relatives in the area, so what we have to say is welcome home, and we're so glad to have your skill set here, and we know that you're doing fantastic work for us, so thank you for that. And we want to talk about your involvement and your connection with this model called the Back and Spine Center. So in a previous show, I spoke to the medical director, Dr. Michael Braxton, and he educated us somewhat on what back and spine was. And one of the focuses of Back and Spine, of course, is the fact that it has the ability, the program has the ability to bring these disparate yet connected specialists together. So where do you see, how does a neurosurgeon fit into that model?
Yeah, so I think that it's become such a necessary and critical component of spine care. With an ever-aging population and the incidence and frequency of neck and back problems, the goal of treatment is more than an individual component. So the goal here is to bring ideal care together, and that includes, under Dr. Braxton's leadership and some of the roles he's able to play, maximizing and offering treatment to avoid any surgical intervention. And I think that's always the goal. So working with Dr. Braxton and the physical medicine rehabilitation side, physical therapy, interventions, which are minimally invasive or non-surgical, from epidural injections to other opportunities that are all inclusive within the treatment paradigm. And then where I come in is in the surgical arena, where oftentimes it's very obvious, and surgical consultation is indicated, whether or not there's more severe pathology than just pain, weakness, other loss of coordination, hand function, and critical components that come along with a complex system of the spinal cord and nervous system. So the component role I play is to be a team player, be able to identify upfront and evaluate patients that require surgical consultation, be able to help in the component of triaging patients for the treatment that they need and require, which is usually and often not surgical, and to be able to provide all this in one hub, I think is really necessary for the modern treatment of spine disease.
And what we learned from Dr. Braxton was that it is so important that you all are physically co-located at certain times, where he can walk across the hall and ask a question, or say, I have this patient I'd like you to see, or I'm going to go in this direction. What do you think about that? And we've seen now throughout the advancement of the Back and Spine Center model that we are getting better outcomes, and we are able to maybe reduce some cost. And if you look at what's happened in healthcare in our country, we see that costs were escalating disproportionately to inflation or GDP or many other factors. So not only does this program give better outcomes, it also strives to be the most cost effective. And we know that you are brought in when either absolutely necessary or absolutely obvious that we need to have a neurosurgeon. So let's talk about the team approach to care in our next slide.
I think that in addition to everything that you stated, it's also a very patient-centric or patient-friendly approach. It's the same thing that I would want to be able to utilize, in the sense that it's not cost-effective, one, but it's also frustrating, I think, on the side of patients when they end up in the wrong spot. So oftentimes, I don't need to evaluate a patient. It's better cared for by Dr. Braxton. And oftentimes, there's an obvious problem that needs a surgical evaluation. So part of that component is also not wasting time, ending up in the right spot early on, with the right care and the right pattern of treatment, which leads to success in all the metrics that you described.
So we see that, if you go back one slide, Dr. Hayes, we see that there are a whole group of different specialists that are involved here, including physiatrists, and we learned earlier today that that's called a PM&R position.
Correct.
Physical rehabilitation. And we have, of course, your specialty, neurosurgeons, your surgical residents, and registered nurses, advanced practice nurses, physical therapists, not so much occupational therapists and social workers, but those come in at different points throughout the care continuum if needed. So you get to interact with all of those folks, don't you?
Oh, absolutely, and that is the critical component of developing, what we're defining as a back and spine center, is having all the components for multidisciplinary care to optimize outcomes, get patients in the right location. But a key component to there is communication. So having a network of communication with individual specialists and providers is the key. So that's not to be undermined.
Right.
It's so critical.
So your physiatrist can walk across the hall and talk to a pain specialist, or he can walk across the hall and talk to you, or he can walk across the hall and talk to physical therapy, all of those things. And we know that not having to wait a couple of weeks to see someone or longer is even more important to the overall effectiveness of the program. And we've seen with the Ochsner model, the technology that's in place now to be able to see a physician using your mobile device or using the web is just incredible, because not only can you pick your physician, you can pick the time that you want to see him, and if that appointment time is available. So all of those things weaving in technology seem to be able to, and we've demonstrated that we're getting some really good outcomes for that. If we had to, in our next slide, talk about the goals of the program, what would you say as far as what's the most important thing there?
I think that they all tie together, but the goals are to optimize and streamline the care of back and neck problems. And to be able to do that and make it functional, I think that we've been through all the components to achieve the goals, which are optimizing outcome, increasing function, increasing activities of daily living, and individualizing it to meet goals of patients. So if you come with a particular problem, particular setback, and you have a goal to get back to life and do what you want to do, the goal here is to be able to do that in a comprehensive manner and get you to where you want to be. In all of the advantages that you discussed, early access, ending up in the right place with the right provider, getting the right treatment program individualized, and the right advice to get you on the road to recovery is the goal of the program, and to bring everything together in-house and unify it in a team, in a team manner.
One of the technological advances over the last decade has been the advancement in electronic health records, EHRs. With the systems that are in place, and I know that you use the Epic system in the Oxygen network, and Epic is, I believe, the largest vendor now of EHRs in the country. You have an opportunity through the Oxygen system to be able to access both medical records, lab results, images. How has that impacted the way that you treat and the way that you deal with your patients?
I think that while everyone deals with frustrations of growth in electronic medical records, I think that it is really changed care. It is invaluable to have information at your hand, like you described, laboratory data, history. I see patients, I can know if they had a heart problem or required any kind of intervention from a cardiac or pulmonary standpoint, being able to communicate with providers within the network and understand what's going on, what their risks are, and that goes back to discussing tailoring individualized care and what's right for a certain patient. Being able to look at their images from 5 years ago and compare them remotely in different settings, offices, clinics, working from home, being able to pull this up, burning the midnight oil. But there are great advantages. And now within Epic, it's even moved to the next level where there are forms of care everywhere within Epic that a patient's medical record from remote or outside of the community, or when they ended up having an accident in Destin fishing, there's access often that's uploaded from remote facilities that we can get within the system. So I think it's tremendously valuable.
And the other component to that, which is it's incredibly important for the practitioners, the patients have an opportunity to have a portal in to be able to maybe help manage their own care, and to see what's going on with their labs, and to see what their physicians are saying about what they need to do to maintain and improve their health.
Absolutely. There's great access, and oftentimes it also enhances communication. We frequently receive e-messages and comments and updates about how people are doing, what they need, how we can help them out through the office. So I think it goes both ways.
All right. In our next slide, we talk about, we mentioned this a bit earlier, but we have a picture here, a graphic of the spinal column, and that's your neighborhood, isn't it? From the brain all the way down to the end of the spinal column. We talk about, when does the neurosurgeon get involved?
Right. So the involvement of me depends on multiple factors. One is patient problems, and the other is imaging, which becomes so important to understanding a diagnosis, problem, and treating a patient, in 2018. So MRIs we review very frequently. MRIs, CAT scans looking at bones, X-rays that show the mobility and alignment of the spinal column is one feature. And the second feature really revolves around the injury to the nervous system, whether that be a nerve or a spinal cord, and what I call is pain plus. So oftentimes people are dealing with arthritis and pain, and a typical management algorithm is working for a treatment plan that avoids surgery. When I call pain plus, involves symptoms that revolve around sensory injuries, tingling, numbness, and motor function are skills that we take for granted sometimes. Buttoning button, hand functions, walking through the grocery store without your legs going numb or getting weak or giving out. So pain plus is often directed to us pretty quickly. So patients that are losing their function and ability usually quickly gets referred to a neurosurgeon with any imaging that suggests compromise or anything that needs to be evaluated. Outside of that, for typical problems with arm, neck, leg, back pain, if it's pain, despite the problem, the algorithm usually goes through, okay, let's figure this out. Let's work on physical therapy, core strengthening muscles, weight loss, vitamin levels, vitamin D, vitamin C, and a program, tailored through everything that Dr. Braxton, has been directing and running through the non-operative side first.
Yeah. So pain is a very common reason that a patient will present to the Back and Spine Center. But when it's pain plus, and you might think about patenting that, I'm just saying, it's got a good ring to it. I'm sure we can see that in one of your papers, which you've written many of. I've done a little work on that. So pain plus is, the plus is we've got these extremity problems, we've got numbness, weakness, all of those types of things.
It deserves a closer look.
And that's very common when they're going to pick up the phone or walk across the hall and say, Dr. Hayes, this is something what do you think about this? Would you look at this? Do you want to see this patient, or should we see
Right, absolutely, because there's a critical decision up front between, do we need to be talking about surgery? Do we need to come up with a plan for you? Or should we sit back here because we think this is probably going to get better without? And that's often where I come in to make that initial decision and help to triage that treatment pathway.
Yeah, I do see in one of the bullet points here is that, in the planning of stages, you are brought in sometimes to help the other surgeons to plan the case. And that's what you're planning the approach, you're planning which procedure they should do, or how you work together in that procedure?
We often collaborate. There are many different ways, many different tools we have to accomplish the same goal on the surgical side. So oftentimes with a discussion of what's best from the standpoint of an approach and how to accomplish that goal, then even within the surgical realm, we often collaborate, have multidisciplinary conferences, and that's the benefit of working with a nice, larger and established group, is that you've always got a consultation, the second opinion, and we do this all the time. We bounce things off of each other to try to optimize outcomes and to be able to move forward for lack of a better word, with the goal of achieving success.
That's right.
As much as possible, every single time.
Every single time. In our next slide, you mentioned earlier the different types of diagnostic tools that you use. You talked X-ray, CT, and MRI. Is there a progression there that you would see, that you go 1, 2, 3, or how does that, are you just an MRI guy, or how does that work?
No, in my practice, it really depends on the problem. Simple problems, a cervical disc herniation at one level, a lumbar disc herniation at one level that may need surgical intervention, typically an MRI is adequate, and it gives you all the information that you need. When you come into problems which may be a little more complicated, like an abnormal alignment or scoliosis or a slipped disc, then all three of these components are typically utilized, and they all give different information. X-rays show alignment, and they're typically done with you standing, how you live your life, while CT scans are great to see bones and specific bony anatomy and structures, and MRIs show the nervous system very well, but those are done laying down, or supine. So you get different information with X-rays when you stand up and take a picture, and often you learn lots from that, and it enhances the diagnosis, and certainly alters the treatment plan very frequently.
So really it's important to have the set to look at the different components of
very
common.
Correct.
Very common that you would see that. So now in our next slide we talk about when a patient has to go to surgery, what do they expect? What do patients, I'm sure you get this every single day, right?
Yeah.
How do they prepare? How long will all these good
This is the most important. This is often the most important question, and I spend hours and countless hours counseling patients when it's time for surgery, and this is the plan. This is what you need. This is the best opportunity for you to improve. That is the critical question. What does that mean? How do you prepare? And some surgeries, to be fair, are simpler. Many that I do are same day, minimally invasive surgery, plan to go home. That's great, and really doesn't quite require the same amount of preparation. On the other end, many people are quite disabled and have been battling this for quite some time. They're having difficulty standing, walking, and have multiple other health problems that have to be addressed. So I like to think of preparation for spine surgeries with some thought of what you can call prehab, or preconditioning before surgery. You want to maintain your posture, standing, flexibility and range of motion as much as possible. Oftentimes with spine pathology, you get secondary hits, meaning that if you have a back problem, you're not walking like you should, and the next thing you know, you're favoring one leg, and then you have a hip problem, and then you have a knee problem. And it's all connected and it's all interconnected, and it's critical to recovery. So as functional as you can be before surgery, optimizing your health, nutrition, ideal weight, our body mass index are all critical components that help with surgery. They decrease the risk of surgery, and they enhance recovery and prevent recurrence. So a lot of thought goes into doing the best you can, and that's not always easy to achieve, but it's a great focus before surgery to be ready.
And I'm sure you get the questions like, well, how long am I going to be down, and when do I need to come back and see you, and will I see you again, or will I see another physician?
Right. No, so from a surgery standpoint, if it's operative, the recovery depends on how bad the problem is. Simple problems, like I said, can be same-day surgery, go home. With any spine surgery, it's typically avoiding bending, twisting, and lifting for a week or two after surgery, but getting back to life quick. The expectations are up. Walking, typical escalation to return to activity is individualized based on what you want to do and what you did before. I have patients that want to get back to golf pretty quick, that are pretty extensive CrossFitters and big into exercise. The goals are very individualized, and it depends on simple non-fusion surgeries, early enhanced recovery, bigger fusion surgeries. Sometimes the recovery plan is escalated over a slower period of time. But unless it's a bad accident, trauma, or unusual problem, the goal is to get up and moving very quickly after surgery. I see the vast majority of the patients come into the office for what we call a wound check to make sure everything's healing well, that their questions are answered typically at 2 weeks after surgery, and then come back at about 4 to 6 weeks for a reevaluation and an individualized recovery plan to get them back where they want to be.
Certainly. Well, we know that this program has demonstrated effectiveness. It's demonstrated cost efficiencies, and healthcare is not free. We all have to pay our way as we go along with it. So if we can minimize those costs and get better outcomes, then we're doing the right thing for the patients. In our last slide, you can see for more information, we give you a telephone number and a website that you can go to learn more information or to make an appointment to the Back and Spine Center. Dr. Hayes, we thank you so much for joining us today. Dr. Hayes has promised to come back to talk about some minimally invasive procedures and new techniques, and we are looking forward to that. So from all of us at HealthQuest, we thank you for joining us today. Have a healthy day.